Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us today for the first part of our new four-part series. We hold these truths, perspectives on health disparities, racial identities, and cultural humility. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. Like with our risk management roundtables and telehealth community chats, each part in this series will earn you 1 CE credit. Today's webinar, Intersectional Perspectives on the Pandemic, Cultural Fissures and Calls for Change, is being presented by Drs. Brenda Ingram and Keisha Holden. We've placed a summary of their impressive credentials and accomplishments on a slide for you, but I also want to tell you a little bit more about what makes these women experts in this field. Dr. Ingram is a licensed clinical social worker and educator who has over 30 years working in the trauma, mental health, and education fields. Her dissertation focused on the impact of community violence on the academic careers of African American elementary school students. She provides consultations, program development, workshops, and training on sexual and domestic violence, trauma and trauma-informed care, and cultural competence to various human service agencies, schools, and mental health professionals. Dr. Ingram is the Program Director of Relationship and Sexual Violence Prevention and Services at the University of Southern California Student Health and is Clinical Assistant Professor, Department of Psychiatry and Behavioral Sciences at USC Keck School of Medicine. One of her many roles outside of the university is serving on the advisory board of the African Communities Public Health Coalition. Dr. Holden has dedicated her career to encouraging mental health and well-being among ethnically and culturally diverse families through research, programmatic initiatives, and the development of innovative strategies for informing health policies. She has placed a special emphasis on addressing the needs of underserved and underrepresented populations that are often overlooked, yet prevail in contributing to the myriad of health disparities. Dr. Holden is the Poussaint Satcher Endowed Chair in Mental Health and Associate Director of the Satcher Health Leadership Institute at Morehouse School of Medicine, and is Professor and Director of Research and Scholarship for the Department of Psychiatry and Behavioral Sciences. In addition to her own journal and book publications, she has served as a guest co-editor for Ethnicity and Disease and the Journal of Healthcare for the Poor and Underserved. We are very fortunate to have both of them with us today. I am excited to hear both of these women and to share them, their insights, and their expertise with you today. Sit back, relax, and enjoy. Drs. Ingram and Holden, thank you for being with us today.
Thank you, Dr. Martin. I really appreciate that fabulous introduction that you gave us. And good afternoon and maybe good evening. I'm on the West Coast, so I'm kind of guessing it's close to evening time where if you're on the East Coast. So just real quick, our learning objectives for our presentation today are going to help you to be able to define trauma, in particular racial trauma, as well as trauma-informed care. We're going to look at the signs and symptoms related to that. We will articulate a theory around intersectionality, which will be a very interesting way of looking at trauma. We're going to talk about intersectional trauma, which may be a new term for some of you. We're going to apply a trauma-informed framework as to different types of practice skills you will be using. We will also describe those practices and address them in terms of how they work from looking at racial trauma as well as COVID-19. Then we're going to also talk about and identify the impact of psychosocial, social cultural, as well as environmental issues on health equity, and delineate any strategies for coping with the interrelated complexities, or even intersectional complexities, if you will, of COVID-19 and mental health. So first, we're going to talk about the impact of intersectional trauma on Black, Indigenous, people of color, or BIPOC communities during these times where we're looking at racism and COVID-19. So first, I want to talk a little bit about trauma, and it's important to understand that trauma is not just about acquiring knowledge. It's going to change how you view the world. It's going to hopefully impact your compassion and make you a little more compassionate once you understand why people are doing what they do and how it's related to the trauma that they have experienced. We're also going to be looking at how you can change that helping paradigm and move out of this sort of psychopathology and understand that this is what anyone might go through. And so we don't want to be asking about what's wrong with that person. We want to look and focus on what happened to them and to understand what that impact has on what might be presented in the counseling room. So first, I want to talk a little bit about what trauma is and also what trauma isn't. Coming from Los Angeles, I always throw in there traffic trauma, even though people may or may not agree with that, and it may not be part of the official definition, but if you've lived in Los Angeles for any period of time, you understand what I'm talking about, or if you live in any congested urban community, you recognize traffic trauma. But it's
Atlanta
really,
too.
yes, and it's really, exactly. And it's really about an event or a series of events that tends to overwhelm the mind, the body, and the spirit to stay in balance. It overwhelms us in order to cope with different things. And so that's why understanding trauma is so important. It can be any time that we experience a threat to our life or to any part of our body. We will potentially develop traumatic responses. Any sort of harm, and in particular sexual harm, can cause post-traumatic stress disorder to develop. Any intentional harm or injury is also included in this, where again this sort of betrayal part can be seen. Any exposure to the grotesque. Again, we all witnessed the videos of George Floyd being killed, and that had an impact on folks, a very visceral impact. Even though we weren't there, we experienced that sensation, and many people developed traumatic responses as a result of that. Any sort of violent loss of a loved one, could be to suicide, could be to homicide, could even be to an accident, can create a traumatic response. The witnessing or learning of violence to a loved one is another way. One of the reasons why we want to protect children from domestic violence exposure. Learning that you've been exposed to a toxic agent, and just think about what everybody is doing now that we all have been sort of exposed, and some of us more exposed to COVID-19 and the impact that that's having on our mental health. It could be cancer, it could be HIV/AIDS, it could be Ebola that we had a few years ago. So any times that we are exposed to something that could cause us harm, we're going to have a traumatic response. And then if us ourselves, either accidentally or on purpose, cause harm to someone else, that can create a traumatic response within ourselves. And so this is a place where we're going to be talking about the impact of racial oppression, and to start to, again, wrap your brain around understanding how racial oppression is a traumatic form of interpersonal violence. Even though it may not include any kind of physical aspect, it's important to understand that the oppression piece is what we're going to be focusing on, and how that can create traumatic responses in people. So again, just a little bit about racial trauma. It's kind of a new term, but it really it incorporates all the physiological and psychological impacts that discrimination, microaggressions, all of these sort of acts, and how they are a stressful experience for the people who have them. And so you'll have people of color will be talking about these sort of incidences that occur to them, and those incidents, even of themselves, just in and of themselves, can create this traumatic response in the body. And again, it could be a direct response, or it could be something that they witnessed happening to someone who looked like them, or someone that is part of their community. And so these acts do not occur in isolation. They're usually cumulative in nature. And so they go on and on and on and on over a period of time. And so it could be one single act of extreme oppression or discrimination, or it could be this constant dripping on the stone, so to speak, that can create racial trauma. And so then we also have this term called collective or social trauma, and that just means that all of us are going through it at the same time. We could look at COVID as a collective trauma, and that we are all around the globe experiencing the impact of COVID-19. And so this collective experience has its own symptoms attached to it, its own consequences, its own impacts that may be very different than individuals or individuals put together. For an example, one of the collective trauma outcomes could be that there's more social cohesiveness, that people are together, and that can be a mitigator for the impact of trauma. But if it goes on for too long, it can also show a breakdown in social networks, social mores and values, and it can cause a lot more damage across a large group of people. And so historical trauma is basically, again, the sort of collective trauma that goes across generations. Slavery is seen as a historical trauma. The Holocaust, other types of genocides that people have experienced over a period of time. And it's related more to groups of people, like races or ethnic groups or religious groups. Again, the sort of collective experience that goes across generations. And again, for more information, I would definitely look into epigenetics, which sort of talks about the fact that now we know that trauma will embed itself in the DNA in terms of gene expression, et cetera, without getting into a lot about epigenetics. Feel free to look into that a little bit further. And then intergenerational trauma is very much like historical trauma, except that it goes within a family line. So if your great-grandfather committed suicide, you're at greater risk for using that as a coping mechanism. And so those types of traumatic experiences, it could be child abuse, it could be homelessness, those things travel also through generations along families. And so all of these traumas can be what we call enduring trauma, meaning that there's no end in sight. And when we talk about COVID, we talk about it as an enduring trauma at this point. I think we all thought it would be over with by now, and here it is rearing its ugly head again. And so again, it could be multiple exposures to one trauma or multiple traumas of different types, or what we call polyvictimization. But this enduring nature of the trauma, where you can't escape, where the victim and the victimizer have constant contact with each other. It can be seen in domestic violence, in poverty, all kinds of issues that are going on in terms of abuse or any kind of relational violence. These are considered enduring traumas, and they are extremely impactful in terms, especially for children, where we can see the neural development being impacted by long-term trauma. And then we have community trauma, which again is kind of like collective trauma, except it's on a more neighborhood community basis. And what we find is that the impact of the trauma goes beyond the individual and literally can change a community. Again, and it's based on more of the structural violence that happens. It could be laws, it could be policies around policing in communities, where everyone is over-policed, and therefore that can create a traumatic response in communities. It can also cause communities to be more hypervigilant. It can also create communities to be more aggressive. And so there's a lot of issues that impact communities around trauma as a whole. And so these high levels of trauma, again, can result in breakdown of social networks, social relationships, and positive social norms. And so now we talk about the trauma of COVID-19, the pandemic, as I call it. One of the things that makes COVID-19 so traumatizing is the fact that anybody can catch it. It's airborne, you don't see it, so you can't sort of run and hide from it. And so there are so many ways that it can come into your life. And at this point where we're looking at community spread, you don't know how you got it. You could have gotten it here, you could have gotten it there, and you don't know. And so you get real kind of paranoid as you continue to be hypervigilant around it. The mortality rates are 10 times higher than the seasonal flu. Even though it's only 1%, it's still higher than the flu. We talk about the flu being 60,000 people die from that every year. In COVID, we're now up to, in less than a year, over 220,000 people have passed away from COVID. And so that's pretty scary to know that something's in the air and we all have to breathe. Then so you can't really escape it. But again, it's also important to keep in mind that it's not higher than some of the other diseases that we have, such as cancer, which has a mortality rate of 1.8%. But we don't feel that cancer necessarily is in the air, that anyone can catch it. We look at lifestyle, we look at other issues, and so we don't look at cancer in quite the same way. And so when I did this slide originally, we were at over 210,000 deaths, and now we're at over 220,000 deaths. And the span that happens in such a short period of time is part of what makes it such a scary phenomenon. We know that over 7.2 million people have been affected, and now we know that that's, I think, closer to 8 million now. And then worldwide, the death rate is even higher than what I said is 1 million at the time when I put this together. So the numbers are constantly going up. We're in the middle of a surge right now where Europe is getting ready to shut down again because of what's going on. And so we don't know when this is going to end. And so it becomes this sort of collective enduring trauma that we go through. Again, it's global in nature. We don't have any cures for it. We do have better therapeutics, meaning that if you catch it, our rate in the US is that less people die from COVID than, say, in some other countries of people who contract it. But because we are such a huge country in terms of the number of people, the impact can be more devastating across all of our communities. And so we don't know a lot about it. We're now hearing about some of the after effects. Once people have gotten over COVID, they still have some lingering things attached. So for all of these reasons, we are constantly in what we call a fight or flight response in our bodies. We are on edge. And so you see this in terms of people having problems with making decisions. They talk about COVID brain and being zoned out, sort of walking around in the fog. I think when we first had it, the first few weeks, I was like, okay, I got this. And then at one point it was like, oh my God, this is still going on. And then you find that you think slower than what you normally would do. You don't problem solve as well. And what you're seeing in terms of what's going on in the community, where people are acting out in more ways. In LA, what we're seeing is people are driving over 100 miles an hour. I know it doesn't happen very often. And so now that people have that opportunity, there's less people on the roads. I think they've gone up over 8%, not 8%, 8 times higher traffic tickets now just for people driving over 100. And so you see these increased acts of microaggression reported a lot by our Asian Americans, where people we're pointing the finger at them and taking it out on them for the COVID-19. We see obviously more racial unrest. We see, and again, these impacts tend to land more on marginalized communities. And again, it's about power. It's about health disparities that you're going to be hearing about, or health inequities. We know that mortality rates are 3 times higher for Blacks than it is for whites. We know that Native Americans, there are 31% of COVID cases in New Mexico. And we know that Latinx has some of the highest rates of infection and mortality. And these numbers are just growing, unfortunately. And again, people of color, poor people, they tend to, that these sort of phenomena tend to hit them in a harder way. So when we're talking about this, I want to bring in this issue of intersectionality, and we've talked about intersectionality now in human services. Pretty much everyone has heard about it. But basically what we're talking about is where all of these different types of oppressions, it could be discrimination, it could be you're oppressed for whatever your social identity is, and we all have multiple social identities. And so these identities that are part of a group that's discriminated against, or a group that's powerless, will have a greater likelihood to have multiple traumas where these things intersect. And so the impact of these various traumas is that it can create more health disparity, more health issues for those communities. And so you see that there's these overlapping intersections when we're talking about intersectionality that help us to understand how these things move together and interact with each other to create more trauma, and actually more complex trauma than what you might see in the dominant culture. So when you are a Black woman or a Black trans woman, you're going to have these social identities are going to be impacted by trauma greater than if you were a white female who was having the same types of experiences. Okay, so again, we all have that commonality of what happens to us as women, but also you have to add race. You have to have gender identity. And so all of those things that tend to be marginalized in our community will make more trauma for the person who carries those social identities. And what you see then in these circles are where they overlap and what are some of the outcomes related to that in terms of more mental health issues, lower self-esteem, lack of housing, lack of economic stability. All of those things can impact our mental health and well-being overall. And so again, to talk more about this intersectional trauma a little bit more, again, it is the physiological and psychological reactions, just like we talked about with other traumas, of people who have these multiple social identities. And these identities have been impacted by harm or violence because of the multiple oppressions that are attached to those identities, okay? So this type of trauma, again, can be way more impactful than if it's a single trauma, and can be obviously way more complex than what traumatized people from the dominant culture particularly. And so each social identity may have different levels of trauma, may have different types of trauma. And so we have to look at those social identities from a racial, from a gender, and even our hidden identities. So some people who may not be out, who have LGBTQ, who could pass, those create internal types of harm where you have to suppress who you are. So that becomes a traumatic response. If you have a mental disability, so no one necessarily sees it, that's another type of hidden identity that can create and carry trauma experiences. And so, for example, it's more lethal to be a Black trans woman than it is to be a Black woman. Okay, trans women, in particular trans women of color, in particular Black trans women, tend to have much higher rates of murder than Black women. But then it's more lethal to be a Black woman than it is to be a white woman. And so again, you have to look at all of these and do your sort of intersectional analysis, which we can talk a little bit more about later, when you start to talk about what's my treatment plan going to be when I'm working with this individual? How do I recognize the impacts, the intersectional impacts that are related to this person's social identities? And we talk about that's one of the things that we want you to take into account when you're doing your assessment. And so intersectional trauma recognizes that each social identity can have its own trauma impacts, and they can have this synergy attached to them, the synergistic effect that intersects with just not their identities, but the overall arching frame of powerlessness and marginalization, okay? And so this phenomena contributes to health disparities as well as to overall well-being. These marginalized identities have less access to services. They tend to be inappropriately assessed and treated, meaning that they'll get things done or they won't get stuff done. I can tell about a story where a doc talks about, she had a Black female who came in complaining of back pain. And so people just sort of wanted to give her an aspirin and send her on her way. It was a video that was done on cultural humility and how they kept sending her away. She kept coming back and saying, wait a minute, I'm still having back pain. What's going on here? And so finally this intern, or resident, I should say, decided, well, let's just show her there's nothing wrong. And so what they ended up doing is that they did an EKG and found out that this woman had been having heart attacks. So, and again, we all know the story about what happened to Serena Williams, and how they didn't listen to her when she came in. So these sort of marginalized identities, even though we know Serena has access to the best healthcare on the planet, she still wasn't listened to, and so was inappropriately treated, and it could have ended in her death. So these sort of issues based on your social identities, again, impacted by structural and systemic oppression that we want to, again, surface so that we can address those. So trauma-informed care, again, keeping in mind, is this sort of organizational structure that helps us to recognize the impact of trauma, to incorporate that into what we do, incorporate that into our policies and our practices. It talks about the values of safety and making sure that people feel safe and are physically safe, and that safety in terms of emotions, psychologically safe, all kinds of issues around safety, financially safe. all of that sort of stuff, and that we work from an empowerment approach, that we make sure that we do whatever we can to empower that person to change the system or to change their own situation in any way that they can without trying to tell them what to do. And so we always take into account moral safety as well. How am I acting? Am I acting as a person with integrity, or am I compromising that and compromising this person's safety? So we got to look at ourselves and look at where we come from. The system requires that we work with others who are also trauma informed, because it doesn't do anything if I'm trauma informed and I do all this work with someone and then send them to someone who's not trauma informed, who then re-traumatize them, and it could be inadvertently or it could be not inadvertently. But bottom line is that they can be re-traumatized. And so again, we want to make sure that all staff are trained in trauma as well as being trained in trauma-informed care. So these are some of the essentials of a trauma-informed care system. We focus on relationships. We make sure that we build safe, consistent, predictable relationships with folks so that they feel safe. We always promote safety and trustworthiness. If I say I'm going to do something, I need to show up and make sure I do it. And building that trust is hard when you're working with populations that have been betrayed by institutions and you are a person in power. So keep that in mind. How do we situate ourselves within building this relationship is very important. We always talk about respect, engage in choice and collaboration with people that we're working with. We empower them. We are very culturally sensitive in that we understand the role that culture plays, but we don't stereotype it. And we'll talk about cultural humility in a second. We are strength-based, meaning that I'm not here to talk about all the things you've done wrong. I'm here to talk about what you've done right and then build upon that. Mm-hmm. And then we always lead with compassion and support. And so again, incorporating cultural humility is vital if you're working with Black, Indigenous, people of color communities, okay, or individuals. We need to make sure that we have checked ourselves. And so the part of cultural humility where we have moved from cultural competence to cultural humility and know that it is an ongoing process. There is no end road there. But we need to be reflective. We need to stay humble. We need to make sure that we're open to hearing how this particular person and all of their social identities intersect, because it may be very different for that person than someone who you think looks just like them. And so we always want to stay open. We always want to stay available to hear that person's story. And again, and make sure that you are aware of your own implicit biases as well as your explicit biases, because they will come up when you're interacting with folks. Mm-hmm. So keep that in mind. And so we want to know more than just be competent. We want to be open to that person's individual experience of their culture. Mm-hmm. And also the other two parts of cultural humility that people don't talk about is about changing the power. Usually people go to that first one and then don't look at the other ones. And so it's important that you look at how am I as a practitioner, as a helper, going to address power imbalances, not just within the room, but outside of the room of counseling. And then again, developing these partnerships with others to impact system change. It's not enough to be a wonderful, supportive, compassionate person in the therapy room and then go out and vote for policies or people that support policies that are oppressive. That's hard to do. So this is just some of the things we talk about in general about how do you want to promote healthy recovery from intersectional trauma for people that you're working with. First of all, we don't blame the victim. We recognize that people are coming from their context and how that context impacts what we are seeing before us. So we are always empathetic. We validate their experiences. I had a gentleman, a Black client who came to me, had been diagnosed as paranoid schizophrenic because he was telling his workers' comp people that the white folks at the job were out to get him. And well, you got to be paranoid schizophrenic because that can't be true. And so he came with that diagnosis. And when I listened to him and talked to him, there was no schizophrenia. He was just saying something that people could not accept. So the first thing is that I need to validate where you're coming from. I need to accept that your experience is your experience, okay? And we want to develop opportunities for people to tell their stories. It could be in healing circles. It could be given testimony. The more you validate a survivor in terms of what has happened to them, the less they have to act out to get that validation. And that's what we want. We want to speak the truth. We want to teach about trauma. I always teach my clients, trauma. This is a trauma reaction. You are not going crazy. This is a normal reaction to an event in your life that's overwhelming. And that's an important reality to tell people. We want to help them to develop a new understanding of what their trauma means. What is the point to the suffering? What is their purpose in life? How does that make sense to them? How do we help them to develop that new narrative? Again, teaching trauma coping skills, relaxation, yoga, all those sort of things help with people. Again, re-engaging that prefrontal cortex, as we talk about it from a neuroscience perspective, that gets shut down during a trauma response, we want to re-engage that. So the more we help people engage in problem solving, the more we activate that prefrontal cortex, and it can take over in terms of helping people to make better choices. And then we want to build community. How do I connect folks with other people? If you know Judith Herman's model, that's one of the main pieces she talks about, is rebuilding community for trauma survivors. And how do we do that in a way that's positive and supportive of who they are? How do we use cultural practices and spiritual practices as we work to heal somebody? It's not just, again, from this one paradigm. We want to make sure that we look at the whole person. And so these are just some tips on healing the hidden wounds of racism by Kenneth Hardy. And again, not vastly different from what I've sort of said. How do we affirm? How do we acknowledge that person in terms of what they've been through? How do we create space to talk about race? That's one of the things we don't talk about, but we need to talk about. I need to talk about all of your social identities and how they play a role into what you're presenting within the room. So again, creating that space to have the conversation about race that is uncomfortable if you are not of that group. And so how do you get to that place where you don't shut folks off because of your uncomfortableness, okay? So creating that space, that brave space, versus that safe space for you, the therapist or the service provider. Racial storytelling is another way that people can sort of tell what happened to them. So we want to encourage people to do that. Validate through counters devaluation. So when people are saying, well, I think I'm crazy, part of what I do is I validate, no, you're not crazy. You're going through a normal reaction. It's just amazing. I had a woman who sort of was going through the same thing, and she thought she was going crazy. People were shaming her. And I had to come and say, no, you had a normal reaction to being scared. So there's no shame in that. And so again, that counters their devaluation. It helps build self-esteem when people feel that they are evaluated. And so we name it. The process of naming, yes, this was racial discrimination. This was a microaggression. And I can't tell you, if you've ever had microaggressions thrown on you, you're always questioning, is it me or did they do something? And so naming it, making sure that people understand that, yes, that happened, is tremendously healing. And then this external devaluation, counteract that, and then helping people to find ways to rechannel their rage. And so now it's time for us to move into health equity, and Dr. Holden will take over from here. Thank you.
Thank you, Dr. Ingram. I'm sitting here just taking it all in, that I learned a lot about trauma and understanding how deep it is and how deep it can go. And really it bridges nicely to understanding health equity and addressing some of the ways in which we conceptualize health disparities, particularly from the intersectionality perspective, and understanding that people come to the couch, if you will, with different experiences, and certainly addressing various experiences that they may have or have had or experienced, including trauma, different types of trauma, can lead to how a person views their experiences relative to inequities that they may experience or that exist. And so when we think about health equity, I want you to really look at this as an umbrella term of understanding what it means for people to achieve, all people to achieve, an opportunity to have the same potential. No one person is disadvantaged or advantaged over another. And so inequities exist in different communities, particularly underserved communities, at-risk communities, vulnerable communities, many of which that I work with at Morehouse School of Medicine. And so understanding the inequities and the desire to achieve health equity or advance health equity, get closer to health equity is what we're all aiming to achieve. And so again, health equity, when we think about inequities, it's looking at some of these extreme differences that exist as it relates to health, and they are maybe significantly associated with different types of experiences that people have, many of which may be systematic and avoidable, such as racism, sexism, classism. They may be facilitated or exacerbated by circumstances, different events, traumatic events that happen, or they may have experienced, and they also may be intensified by what may be happening in the political climate, what's happening from an economic perspective, as well as a social perspective. So all of these various things may influence how a person is experiencing various inequities in their life, including COVID-19. And this is just a pictorial view of what I'm talking about when it comes to health equity or equity versus equality. Some people may believe that, okay, just give this community X, Y, and Z, a one-size-fits-all approach. And that's not really the most appropriate way to look at it. Equity is really about giving people what they need when they need it, and then the amount that they need it. So it's not this one-size-fits-all approach to various individuals, families, or communities, but looking at getting more specific to that person or that community or family and determining, okay, this may be the support that's needed to help advance them to get closer to health equity. And so here's just a list of some of the biopsychosocial, cultural stressors that any number of which a person may experience at different points of time in their life. I do want to acknowledge that rarely is it just one particular topic. It may be any number of these different topics that interrelate or may be experienced at the same time, such as health concerns or health problems, such as COVID-19. We know that's certainly prevalent in our communities, individual or personal issues, interpersonal challenges, family dynamics or challenges, demands that may be happening, unresolved pain or trauma that may be experienced, such as sexual trauma, emotional trauma, physical abuse that may have occurred or occurred currently, negative life events, and the list goes on and on. And I bring this up because as I mentioned, it typically is not a situation where one person is experiencing a particular problem or challenge at one time. It's typically a combination of these various types of stressors. And these kind of stressors certainly can elevate risk for any number of different mental and behavioral problems and ways in which they may cope with those various issues. And so here I just want to indicate that when it comes to COVID-19, there are a number of different mental and behavioral issues that many people have experienced. There have been, over the last several months, increase in domestic violence reports. Suicide prevention hotlines have been an increase in receiving calls, as well as abuse neglect cases that have been acknowledged, and the list goes on and on. I will say that especially when it comes to how we've had to adjust from a perspective of knowing what is healthiest for us when it comes to COVID-19 risk, sheltering in place or physically distancing, for many people, that may also increase their risk for having a sense of loneliness or isolation, feeling helpless, a sense of loss, and any number of different kinds of issues that may be related to mental health problems. But it definitely negatively affects or has negatively affected many individuals, and they may become increased worriers or at increased risk for being to engaging in behaviors that are not necessarily healthy for them. And so I just, I wanted to acknowledge that what we're dealing with is pretty serious and traumatizing for many individuals, for many of us. And so we have to be at a point where we get more proactive in how we deal with or address some of these kinds of issues that we're dealing with. And one area that I would say is probably most important for us to look at, and Dr. Ingram mentioned using a strengths-based approach, is resilience, or an approach that really kind of takes a person where they are and building from there. And so resilience really is a complex concept that really is the integration of what's happening with their person psychologically, what's happening culturally, spiritually, but it really determines or helps to determine how a person's going to respond in times of stress. And so being able to build resilience, build on resilience, look within and what's happening with the person may help to stimulate their ability to feel a better sense of power, a stronger desire, or having this tenacity, having an endeavor to strive towards some level of excellence. And so being able to build on the strengths, again, is an important piece for resilience. And here, just from a psychological perspective, here are just some concepts that you can be aware of when it comes to resilience. Certainly having internal local self-control versus external local self-control, and knowing what's happening or how external factors may impact you. Certainly having healthy relationships, a social support system that is healthy and positive, empowering for you or for your clients when it comes to being able to really shape this personal sense of competence and tolerate stress in a way that's going to help engender resilience and being resilient. And here I just want to motivate psychologists, social workers, those who engage with caring for people from a psychological perspective. These are just some items that you can incorporate in therapeutic situations. Certainly developing action-oriented plans, looking at how you can help individuals to remove or alter the stressor that they may be experiencing to some extent, learning how to recognize and anticipate those potential stressors, removing themselves from that stressful situation, and really having a plan of action that's going to help them get closer to having a more positive experience. Reducing vulnerability and building up their resistance to stress is important. And this has to do with really having a orientation towards developing more self-awareness or self-exploration for how they view certain ideological aspects of the world or situations that they're experiencing or have experienced. Reducing the impact of stress reactions, how controlling or modifying how a person reacts to stressful situations. A lot of this may have to do with how a person talks to themselves and what you know as cognitive restructuring, so that it's more of an orientation towards reacting in a more positive way. And this kind of aligns with resilience skills training. And this is more around how a person responds to or reacts to or reduces the impact of the stressor or stress situation that they're dealing with. I have a project a research project that I am the PI on that is around resilience skills building or training for those who are at risk or diagnosed with post-traumatic stress disorder. And so being able to reshape how an individual reacts to or responds to stressful situations is certainly important. And of course, self-care and determining how to better monitor themselves, look at positive thinking, imagine themselves from more of a positive visualization perspective, positive reinforcement, taking action to stop self-destructive behaviors, and on and on. So all of these items will be available to you in the slide deck that you'll receive from going to the Trust's website. And finally, I just leave you with some different resources that you can access from the American Psychological Association, from the National Alliance of Mental Illness, or NAMI, relative to COVID-19. There's a guide to global healthy living as it relates to COVID-19 that you can also access resources about. And all of these are designed to really help you, to help your clients better respond to or react to what they may be experiencing concerning COVID-19.
Well, what a fabulous presentation. You all have done a wonderful job. We should have scheduled this for longer than an hour. There's no question. Thank you so much for your helpful information. We're going to try to squeeze in as many questions as we possibly can. First of all, Dr. Ingram, I'm going to address this one to you. In general, what can psychologists do to address racism in their sessions with clients and in their practice settings? And more specifically, what can psychologists of color do, and what can white psychologists do?
Thank you for that question, Dr. Martin. And obviously that's a huge question, because there's so many things you can do, and it also can be very complex, the answer. But I think the first thing that all of us need to do, regardless of our ethnicity, is to validate what the person said. One of the things that I was doing was also looking at some of the questions in the chat, which also sort of speak to this question in terms of what I can do, and what if they're misperceiving a microaggression. I just want to state out to folks that it's on the beholder of that microaggression to define what that microaggression is. So if you are the person committing it, you need to stop and listen to the person who it is landing on. And so hear their story about their experience of that microaggression, because it may not be your understanding. And so being open to hearing that in the room is very important. I always get the question, well, do I bring up race or do I let the client bring up race? And I think it's both. I think, how do you create an environment in your office that says we can talk about differences? What sort of decorations? I mean, I'm talking seriously. It can get to be that kind of a level of understanding and awareness. What pictures do I have on the wall that let people know that this is a safe place to have those conversations? Do I have diversity in my waiting room even? I remember I went to LGBT training like a gazillion years ago, and they gave us rainbows to put in our office, which told people this is a safe place. And so the more of those sort of physical things that you have around you that give that information, the better it is for your client. And so always understanding that I need to make myself the safe person. And how do I do that? It's going to be based on who's sitting in front of you, what you say, and who you are. So being authentic in that regards is one of the best ways of helping people to deal with that. But making space to talk about these issues, because it's going to come up in subtle and not so subtle ways. For example, I had a client who was white and who one could say got very comfortable with me and threw out the N-word. And then she caught herself and she was so embarrassed and uncomfortable. And people asked me, well, is it my job to fix her racism? That's not what she came to me for. That was not one of the presenting problems that she listed. But me being authentic, me being validating, me being compassionate about where she's at in all of this process will help her to move without me saying, oh my God, you're a racist, I can't see you. That serves no purpose for that person. So again, it's about validating their experiences, making yourself the safe person before you jump into questioning what someone said. First, I validate it. I always want people, and another question that came up was around the stigma. It's always about letting people know that you're not crazy. You would be surprised how important that is for people to hear. The stigma of mental illness stops people from getting the help and being open to help. And that could be medication, that could be going to psychotherapy, it could be multiple things. And so we need to address the stigma and talk to people about that. So those are some of the things I think about when we say, what can we do in the room with folks? And then what do we do outside of the room? What do I do as a white therapist? Again, recognize your privilege, recognize your power, and then how are you going to use that for good in the room as well as outside of the room? It's not enough to sit in the room and be compassionate to folks, and I tell this all the time. If you go outside and you vote for stuff that does not support the people that you work with, if you support oppressive policies, if you support structural racism, if you support, and that means that I won't do anything to change it. Doesn't mean I'm going to go out and say, let's have a racist society. It means I am not actively moving to do something different to change that, okay? You need to check yourself. You really need to check yourself, because is this the population you can work with if I am like hidden my true identity? So being authentic helps people to feel safe. So try and be your authentic self. And if you haven't addressed issues, then you need to address those issues. If you are someone of color, let's not assume that just because you are a BIPOC individual that you get it. So everybody needs to get educated on these issues and understand intersectionality and understand multiple social identities and how they contribute to who this person is you see, and how oppression and trauma impacts those social identities. And so you need to not just say, okay, well, this is a woman and therefore these are feminist issues or sexist issues. No, it's what's her ethnicity? What is her able-bodiedness? What is her gender identity beyond being a woman? Maybe that's a trans person. What is their sexual orientation or their sexual attraction? What role does that play into what's presenting in the room? So taking all of those particular social identities in account when you do your assessment, or in this case, our assessment is really our intersectional analysis, will help you to come up with a treatment plan that is appropriate for that individual, not necessarily based on stereotypes. Mm-hmm. So that's true for anybody. And people of color, I think, also can be triggered when working with someone who's coming in to talk about their racial oppression. So if that person looks like you can over-identify at times and maybe not address certain things that you should address with that individual. So again, it's always great to have someone you can go and debrief and talk about these issues with, who can give you another lens to assess what's going on inside of you. And a lot of times, you know, if you are of color, you may think, yo, I got this and I don't need to think about this. And you could be very wrong. So again, we all need to look at our own stuff and we need to unpack it, because people of color carry internalized oppression. Mm-hmm. And that can be in terms of internalized sexism, internalized homophobia, internalized transphobia, internalized racism. So we carry that just like everybody else carries it. And so everybody needs to do their homework on looking at their own implicit bias issues.
You know, I think you pointed out a lot of very interesting points. Dr. Holden, you have something you'd like to add?
Well, I was just going to say, in that same family of discussion, Dr. Ingram, which was really great, is that I think it's important too that we create support systems or friendships or the of people who may not look exactly like us, that can provide some different kinds of perspectives. And so, you know, having different kinds of individuals in our circles, I think would be good.
Excellent point. Let me squeeze in another question if I can. And Dr. Holden, I'm going to direct this one to you.
Okay.
Speaking about support systems, let's segue back to some of the points you made about resilience and coping. So what do you believe are the most significant factors that psychologists can engender to facilitate healthy coping during this public health crisis?
I think that it's important. I mentioned this around this internal locus of control. Yes, we all have certain aspects of our environment to respond to or that we know are important, but I think it's important for psychologists to really work with clients to understand how they shape their views about certain situations and how they react to certain situations is going to be key to how they are able to cope best with certain situations. Particularly when it comes to systematic level issues, it's you know, it's not as if you can change everything or you can be a part of the change, but certainly your reaction to it is important. And so again, this stress management part is key, and being able to reshape or reduce your vulnerability to or how you react to certain stressors, I think is important. And that helps to again, reduce vulnerability to certain things, and knowing that you can deal with it or handle it or take it, or it's not your problem or issue. It's really outside of you. So, but again, the internal locus of control will help you to be able to do that. So I think psychologists should definitely focus in on that aspect of things.
So, Dr. Holden, I'm going to follow up with another question that's related to resilience from one of our audience members who asked,
Okay.
are there developmental race differences in the way we learn resilience?
Mm-hmm. I would say it's not a yes or no, it's and yes. To some extent, just because they're different experiences that culturally that people of different ethnicities have or have experienced. But when it comes to resilience training, there are some standard lessons, if you will, that you can learn. But again, it goes back to who you are and how you're going to use your abilities and strengths to be able to cope with different scenarios or situations. But there are definitely differences that exist. But there are some standard resilience-based or training aspects that can be taught to different groups regardless.
Right, great. And once again, opportunity and access is critically important, both to learn the material, but to have experiences in which one can see one's own resilience. So Dr. Ingram, I have a question for you. It's actually for both of you, but we'll start with Dr. Ingram. How do you make a distinction between acute or chronic stress as opposed to trauma? Is it not true that not all stressors, even severe ones, are experienced by everyone as trauma?
Yes, it's correct. Trauma is a very subjective experience. And so it depends on a number of factors, including all of your social identities. But it can be very different based on your age, based on the type of trauma or the type of event that you experienced. It can be different depending on your gender. Men respond differently than women respond. And so again, all of those sort of interacting variables, if you will determine whether or not it becomes a trauma. And so again, it is on the person who is having that experience to define it as such. And so some people, because they've had like a whole bucket of trauma, had a lot of, someone had asked what are ACEs, adverse childhood experiences. And so someone who's had a lot of adverse childhood experiences, which could be poverty, discrimination, again, these are more external ones than in the home, which the original study looked at, or child abuse, they are going to have, they're going to be more susceptible to other stressors that are going to sort of push them. I kind of say we have this bucket of trauma experiences. And so if that bucket is pretty filled up, one little drop in that bucket can make it overflow. Whereas someone who hasn't had a whole lot of those experiences can take a few more drops in that bucket before it overflows and overwhelms them. So yes, trauma is a very subjective experience. You can't say everything is, this is all for one person and everything fits everybody the same. So again, it's based on your assessment. And I really say, I listen to what my clients tell me. If it's a trauma for them, then I need to address it as a trauma.
Yeah.
And not invalidate their experience.
And I also in alignment with that is we can't compare trauma that people have experienced. I went through this, and so I mean it's really individualized, as Dr. Ingram mentioned. It is definitely subjective and based on how the person interprets their experience to be. What may be traumatic to someone else may not be traumatic to me. So, you know, recognize.
Absolutely. Yeah. I think one of the also important things for us as clinicians, and Dr. Ingram, I'm going to address this to you. What impact do these traumatizing events have on psychologists, and how do mental health practitioners take care of themselves during these traumatic events?
And again, great question. We are, right now, we are all in this pandemic, mental health providers as well as our potential clients or customers. So we are all experiencing that. And I've talked to other mental health providers, and we're all going through the same kind of thing. It's even beyond a parallel process. It is the same. We are part of this collective experience around COVID-19. And so what we say in terms of self-care, we need to take on for ourselves as well. Many times we take on everybody else's pain. So because we are the vessels for other folks, we have to be very diligent in our self-care. And so taking time outs, making sure your life is in balance, doing things that are physical is very important when you are experiencing trauma. And again, it doesn't mean you got to go out and run a marathon, but it means maybe you get up from your desk every hour and move. It's so important to keep movement. It could be dancing, it could be whatever you want it to be, but keep moving is so important because again, it raises some of our neurotransmitters such as serotonin, dopamine, which helps to calm us down, which helps to regulate our brains. So we all have to do the same thing that we tell our clients to do, and that is practice self-care all the time. I talk to employers about making sure that we have self-care days. And you know, going back to the stigma question, I used to say mental health days, and people don't want to take a mental health day because that means I'm crazy. So take a self-care day. And a self-care day is so important for those of you in our audience who are employers or managers or can make those sort of policy statements. And self-care days are like sick days, except we take them before we get sick. And so you don't have to plan 3 weeks in advance to ask for permission. If you wake up that morning and you're not feeling it and you are not mentally able to hear another trauma story, take a self-care day. And it's so important to have that flexibility. When we talk about trauma-informed care, we also need to talk about trauma-informed organizations and how they set up workloads for their folks. And if you see trauma survivors a lot, you should not be seeing that many people. I tell my clinicians now that I supervise, keep it to 4 people in a day, especially if you're hearing a trauma story. You need that space. Have time for debriefing, but with other people. Just talk about it. So there's so many things that you can do to take care of yourself. But the first thing is to develop that awareness that you need it more than your clients need it, because how am I going to be here for you if I'm not here for myself? And clinicians and helpers are notorious for not getting help until the end. That's one of the reasons why we have one of the highest suicide rates, is that we don't get help. So get the help, get the self-care, take care of yourself before you get to that point.
That actually, I see a psychologist, and that's a part of my self-care. It's not based on a particular problem, but it's more prevention. And I think that as psychologists, we can do more of kind of demonstrating to others we're in therapy too, or we see the benefits of talking with someone who can help us problem solve, someone non-biased who can support you. So,
Absolutely.
yeah.
Absolutely. Yes. Early on, we talked about taking care of yourself in several ways. Dr. Holden, you went through a lot of information, which is available on the slides. Thank you for providing that. We have to be aware of compassion fatigue and vicarious trauma. It's real. It does exist, and it is our job to take care of it. So let me ask a few shorter questions, I think. One is, what do you mean by moral safety? Dr. Ingram, I think you referred to that.
Moral safety means that I act in a way I'm trustworthy, I have integrity, I do what I say I'm going to do, I do the right thing. And that's moral safety. And so when you're with a client, you want to engage in that. So I don't want to lie to my clients about stuff. I don't want to raise false hope around things, and I don't want to exaggerate stuff. So I have a responsibility to be truthful and to help people with truth, and not to lie to people about things. And again, stuff is difficult to talk about. It's my job to have the hard conversations at the table. And so I purposefully attend to those issues and making sure that I am acting in an integrity fashion with everyone. If I tell you I'm going to show up, I show up. You don't have to show up, but I need to show up. So again, that's what I mean by moral safety, is doing the right thing. And it may not even fit the law sometimes, but you need to act in a moral way. That's offline. We'll talk about that.
Yeah. So
feel free to email me.
Right.
I will never say break the law.
No, you did not. No, you did not. So unfortunately, we need to come to a close, but I want to offer each of you an opportunity to say any last closing words, any last things that you really want people to take away from this presentation. Dr. Holden, would you like to start?
Sure. I just want to say it's important that as psychologists, we all self-monitor ourselves. We track and monitor what's happening, how we're feeling, so that we are capable and armed to provide the kind of support and care for others. And so I just really want to reemphasize how important it is for self-care. It doesn't have to be some grand thing. Give me small things that we do to take care of ourselves, and so we can take care of others.
Excellent. Dr. Ingram, any closing thoughts?
I think just to stay on the theme of self-care is to also emphasize self-care for our clients. Many trauma survivors neglect their self-care, and doing trauma work feels like it can be hard and complex, but really, if you can get folks to focus on self-care, and that means removing themselves from situations that are highly stressful, to taking a bubble bath, or going and getting themselves an ice cream cone. Some nurturing activities, getting away, you know, hanging out and hiding out, if you will, even in your backyard. I think all of those types of experiences of self-care build self-worth, build self-esteem, and that again feeds into our issues around resilience. So making sure that people incorporate self-care into their daily lives will make them feel better and will normalize what they're going through.
Right.
As opposed to, again, using a pathology model. I strongly push that we use a wellness model, because most of what we're going through is stuff is trying to knock us off our path and throw us out of balance. And we need to come from a wellness perspective.
Absolutely. Well, I cannot thank you both enough. This has been stimulating, invigorating, inspiring. It's certainly been educational. Thank you very much. And I appreciate the way you all have worked so well together. And thank you for speaking your truth. Thank you for sharing it with us. Thank you for putting a name on things that need to have a name. Thank you very, very much.